Bir sonraki konuşmacımız Profesör Doktor Jörg Kleeff Almanya'dan oligometastatik periampuller tümörlerde cerrahi yaklaşımı anlatacak. Next speaker is Professor Dr. Jörg Kleeff from Germany. His topic is oligometastatic tumors, periampuller tumors in surgery. Please.
Dear Chairman, ladies and gentlemen, thank you very much for the introduction. Thank you also for the kind invitation. It's a pleasure to be here. And I'd like to talk in the next 15 to 20 minutes about surgery for oligometastatic pancreatic tumors. Now, first, I'd like to briefly discuss what is oligometastatic. Well, obviously, usually we have local tumor growth where we go on with surgery and we try to cure the patient by removing the tumor. And on the other side, we have systemic disease that we treat by chemotherapy. Now, this oligometastatic is a third category, and this is somewhat in between. And the idea behind this is that we are still thinking that we can cure the patient by removing the tumor and these metastatic deposits that are obviously not a systemic disease, otherwise it wouldn't make sense. There are different definitions depending on the tumor entity, but usually it's defined as less than 5 metastases, and usually it's also only one organ. And obviously tumor biology is the most important aspect, and there's a lot of research going on and we know something about this, but there are still many questions that we have to answer to define this group of patients. I show you one example why tumor biology is important. This is actually not a pancreatic cancer patient. This is a patient with a colorectal cancer. 3 years after the primary resection, he developed 2 liver metastases. So we went on and resected these 2 liver metastases. And then we did the first control scan 6 months later. And what you see is the liver is full of metastases. So obviously, this is not a good candidate for any surgical procedure. And that's why it is really important to define what we mean with oligometastatic and to define also biomarkers that point towards this disease entity. Now, I'm not talking about colorectal cancer, I'm talking about pancreatic cancer. And I just go back a little bit where we were 20, 30 years ago. At this time, the survival rate was extremely low. And those few people that survived pancreatic cancer probably had the wrong diagnosis. And on top of that, surgery was also dangerous. So we had mortality rates 10% or higher, in some publications even 30%. So this was kind of the stone age of pancreatic surgery, and there were even people saying, well, considering this, don't operate these patients because you do more harm than you do good. Now, obviously, this has changed, and you have seen some of these data now. We are much better. We are in a different era of pancreatic cancer surgery, and this is what we can reach nowadays. This is from Japan, surgery and adjuvant therapy, and there are many more of these examples. So we are up to 50% if you do a good surgery and if you do good adjuvant therapy, and that's a different survival of what it has been for many decades. And this is the result of that we can do surgery safer, so we have better perioperative care. We also do surgery more aggressive, and I think you will hear about this later on. We do more vascular resection to get margin clearance. And of course, it's also because we have better multimodal therapy. You have heard this neoadjuvant therapy, more effective chemotherapies. So taking all this together, obviously, the next step would be, like it has been for colorectal cancer, to ask the question, well, what do we do if we have limited metastatic disease, oligometastatic disease? Can we go on and resect these metastases? Does it make sense? Do we do more good or do we do more harm? Now, this is one of the first series, and this was in the time when I was in Heidelberg, and we published this with a limited amount of patients, and I will show you this, what happens if you resect pancreatic cancer plus metastases. And we had quite problems to publish this paper, and at the end we finally did this. But what you can see here, small patient numbers, and on the right side, if you look at the survival curves, you see one thing: if you have lymph node metastases that count as distant metastases, they survive obviously better than peritoneal or liver metastases. But the comparison is difficult, so we try to compare this to a cohort of patients that were operated but not resected. And what you can see from this graph is if you resect the metastases, obviously you can prolong median survival, although the comparison is difficult. But it also shows, at least in this cohort, that you don't have long-term survival. So they all die of the disease, even if you try to resect them. So the conclusion at this time was, well, you can do it for peritoneal metastases, you can do it also for liver metastases, it is safe, but it shouldn't be generally recommended. On the other side, lymph node metastases, and we're talking about this further on, they were not part of this group because lymph nodes have a much better prognosis. So if you have lymph node metastases that count as M1, like distant metastases, you should still go on and resect those and the primary tumor. Now afterwards, there have been a lot of case reports after neoadjuvant therapy of a resection of primary tumor and metastasis and small series. If you try to summarize this, and this is what we have done, you see again there are few patients in these studies, and the conclusions are you can do it safely. So morbidity, mortality rates are low. This is clear, but you also see that the survival is somewhat disappointing. Median survival of 6 to 12 months. This is not really something that we aim for if you operate patients. And this is also shown in these two larger series, liver metastases, resection plus primary tumor. You see you have median survival in one study around 6 months, in the other study around 11 months. So this is not really satisfactory. I'll show you the largest series now coming from Heidelberg, also including our initial series. You can see both synchronous and metachronous metastases were included in this series. Liver metastases were the largest group, and they were almost all oligometastatic. You see very few, most of them had 1 or 2 atypical liver resections. There were very few with more metastases that have been resected. And this is the overall survival in this group of patients. You see you have a 12-month median survival, which is good, but is obviously not something that we are really satisfied. And if we look specifically at the liver metastases and compare synchronous, metachronous, obviously the metachronous, they survive longer than the synchronous. You have 11 and 15 months. And you have to compare this to the most effective chemotherapy we have nowadays. This is FOLFIRINOX, and you see the median survival is almost the same. So the question is really, do we do any benefit for these patients if we perform this kind of surgery? But what the Heidelberg group is rightfully pointing out is, if you look on the left side, you have long-term survivors. So there are a few percent of patients, less than 10, that survive long-term if you resect the primary tumor and the metastases. So there is a group of patients that obviously has a benefit from this approach. Another question is, what do we do if we know this beforehand? We know there are liver metastases, and in this study they just looked at patients treated with FOLFIRINOX in the metastatic setting, and then they resected those where the metastasis disappeared. And you can see here high R0 resection rate, almost 20% complete pathological response, and a very long median overall survival. I'll show you in the next slide the survival curves of overall survival and disease-free survival. Of course, this is a very selected group of patients, so these are the ones that respond. But it might make sense for those that respond to neoadjuvant therapy in the metastatic setting to go on and resect these patients later on. I talked about liver metastasis so far, a completely different story, and I just want to show you this in the next few slides, are lung metastases. And this we know since quite some years. This is some study looking at overall and disease-free survival in patients with lung metastases only that were resected, and you see here quite impressive long-term survival rates. And this has been shown now in numerous studies. In this study, they looked at metachronous lung metastases, and the better survival curve, these are those that have metachronous metastases in the lung, and they are much better than in any other location. So lung metastases have a different tumor biology, and obviously it makes sense to resect them. This is a Japanese study looking again at lung resection for metastases, and you have very impressive long-term survival rates in these patients with isolated lung metastases. Something similar is showing here. If the lung was the only site of metastases, you have by far the longest survival. So lung metastases have a much better prognosis, and I show you also this study because they looked at the treatment then later on, and you can see here that if you resect these lung metastases or you do stereotactic radiation, so local treatment, you have much better survival than if you do systemic therapy. So it makes sense to resect isolated lung metastases for pancreatic cancer. Just one slide for peritoneal carcinosis. You know, there are different treatment modalities we have. We can perform cytoreduction and do intraoperative chemotherapy, HIPEC. And the question is, does it make sense in pancreatic cancer? There are a lot of trials going on in the adjuvant setting where it is obviously safe to do this as a prophylactic measure. In the palliative setting with peritoneal metastases, as of now, and this is like published this year, it is not only not safe, it is also not useful. So it doesn't make sense to do this kind of procedure for pancreatic cancer if their peritoneal metastases don't operate these patients. Now, at the end, I want to show you one study we published last year where we looked at the SEER database, you know, the American database, and there were like more than 11,000 patients included in this study, and we could confirm some of the findings I was showing you. The lung metastases had the best prognosis of all metastatic sites in this cohort, like 6 months compared to the other sites. And if you resect these lung metastases and the primary tumor, you could more than double the survival. So also in the SEER database, it is clearly shown lung metastases are good to resect. And then we put together all the published evidence we have on lung metastases. And if you have metachronous lung-only disease in pancreatic cancer, you have very long survival rates. So obviously this is a different tumor biology. And there were some risk factors or some positive factors. If it was only a single metastasis, obviously that was better than multiple metastases, and a long interval between metastases and primary tumor resection. Now, these are the survival curves for liver and for lung. So if you look on the left side, the right curve, these are patients with liver metastases that have been operated for the primary tumor plus minus metastases. And you can see here also in the SEER database, they have prolonged survival. If you wanted to look just at the metastatic resection, this is on the right side, it is more difficult because the cases are quite, the number are quite low, so it's not significant. On the left side down, you see for lung metastases, again, the red ones are those that are resected, the primary tumor plus minus the metastases. And again, you see here a significant increase in median survival if you resect these oligometastatic patients. Now, obviously, at the end, we don't have very good evidence. We have evidence from databases, from single trials. We don't have any randomized controlled trial. There's one currently going on in Germany, and we are also participating, where we randomize patients that are oligometastatic to some kind of neoadjuvant protocol and then either resect or we keep on doing chemotherapy. And this study will really show us whether it is first safe to do this, to perform surgery, and second, whether there's a survival benefit of this approach. Now, I come to the end and also to the conclusion, just a pragmatic view of what can we, or what is the current best approach in patients with metastatic disease. If you have synchronous liver metastases, and we know this beforehand, I don't think there's any good argument for surgery. So these patients you shouldn't operate if you know that they have liver metastases. If you operate a patient and you detect liver metastases that were not known, it is a very individual decision. It depends whether the primary tumor is resectable. Obviously, it depends also whether it's really oligometastatic disease, and you have to make sure that it's not some systemic disease where you have multiple liver lesions. But on an individual basis, you can resect those patients plus the liver metastases. If you know that they have liver metastases and you perform neoadjuvant therapy, and I've shown you these cases, again, is maybe. I believe if you have a good response, the metastases disappear or are smaller, and you have oligometastatic disease and a fit patient, yes, you can resect the primary tumor and the metastases. If you have metachronous liver metastases, again, it's a maybe. There's no hard evidence for this, but it depends on several factors. Obviously, the patient must be fit, the tumor must be resectable, and the longer the interval, the better. So if it occurs very early after surgery, so within the first year, I would not go for surgery, but if you have more than 2 years, that would be some time period where it can make sense to go on and resect these liver metastases obviously if you don't have any other metastatic site. If you have synchronous lung metastases, again, I would say maybe. This is something where you can really think of operating the patient, especially if it's a single lesion where it's not even clear whether it's a metastasis. This is not relevant for prognosis, so go ahead and operate these patients and follow up the lung. Metachronous lung metastasis, again, a clear yes. If it's lung only, they benefit from surgery. They have a very good prognosis. If you have peritoneal carcinosis, no. There's no way, even if you have single nodules, that does not seem to make sense to prolong survival of these patients. Now, I've shown you we don't have a lot of evidence for these guidelines, but again, at some point, you also need to take into consideration all the possible evidence what you have. This was already what Whipple was saying now more than 85 years ago. I thank you very much for your attention, and I'm happy to answer any questions. Thank you.